everyone, and welcome to WooStream, where we're bringing Willamette to you. I'm Kendrick Arakaki, Assistant Director for Alumni Engagement and your moderator for today. Today's presentation, Epidemiology, Public Health, and COVID-19, will be given by Professor Peter Harmer. Peter will examine epidemiology in the light of COVID-19, what it entails, and the continued widespread resistance to public health recommendations. Peter, a professor of exercise and health science, came to Willamette in 1990 with a dual clinical and academic appointment, and has spent his years challenging students to be their best. In an interview, Peter was quoted as saying, "Students should expect to be challenged. If not, what's the point?" Peter doesn't try to be difficult. Peter tries to do his job, which is to make students better. He was recognized with the Medical Research Foundation 2015 Mentor Award, which honors Oregonians who provide outstanding mentorship and leadership in support of health education and research. He has also collected quite the alphabet of degrees, including a BS, MS, Masters of Education, and PhD from University of Oregon, and in 2006, obtained a Master's in Public Health from Oregon Health and Science University. Before we begin, I want to thank our audience for joining us today. I encourage you to use the Q&A feature during the course of the presentation, as Professor Harmer will answer questions at the end of his slides. You can access this by dragging your mouse to the bottom of your Zoom screen. With that, thank you for joining us today. Peter, I'll turn it over to you.
All right. Well, thank you, Kendrick, and thanks to all of you who have given up some of your time this evening and for your interest in this talk. It's always difficult to make sense of what's happening in a disaster while you're in the midst of it. For the majority of people, the current COVID-19 pandemic has produced unprecedented challenges to our sense of security and community, purpose, and our sense of self. In similar circumstances in the past, people have relied on the expertise of specialists to guide them. But today we know that many are not listening to the science. Tonight, I hope to explore some of the issues revolving around this phenomenon, specifically confusion at the source, the message not connecting, and active opposition to the message. But before I begin, I'd like to give you a quick overview of how I got to this topic. I brought epidemiology to the campus 14 years ago. I've been teaching the class for 14 years. Interestingly enough, almost every year I taught it alternate years. Every time I've taught it, there's been an epidemic. Some people think I might be a little bit of bad luck in that sense. In the years I've taught this, we've had SARS, we've had MERS, we've had H1N1, H5N1, Zika, Ebola, and now COVID-19. And what's been interesting about that, of course, is that every time I've taught the class, the students have had sort of real-world examples of epidemiology in action and getting to understand its strengths and weaknesses as a science and as a way of understanding the world. I also have had some, what I didn't really want, clinical experience with a pandemic. In the H1N1 PDM09 pandemic, swine flu pandemic, which a lot of people, it wasn't that long ago, but don't remember, there were quarantines, there were restrictions on movement to try and contain it. And I was still in my position as the Chief Medical Officer for US Fencing and was the medical supervisor for the national championships that were being held in Dallas that year. And US Fencing Championships, though it's not a big sport in America, there are enough, and it's the national championships are the largest fencing competition in the world. We have more than 3,000 competitors, probably 5,000 or 6,000 people in total, parents and so forth, who were there. And I was informed that we actually had 2 positive cases of H1N1 PDM09 occur. And so it was brought to me as the medical supervisor, in essence, to decide whether I was going to quarantine 5,000 people. Fortunately, I didn't actually have to make that choice. I was able to defer to the local Department of Health, but it made me acutely aware of the enormous responsibilities that are involved in making a decision like that. It's not a decision to be made lightly, and having been in that position, it's made me very interested in the current circumstances of trying to have people engage in appropriate behavior without unnecessarily restricting their freedoms. For the current situation, I also had an early intervention with the SARS-CoV-2. I do a lot of work. My primary research partner is Chinese. We've been working together for almost 30 years since we met at graduate school at the University of Oregon. And our primary work is in epidemiology, but in experimental biobehavioral interventions reducing fall risk in older adults. But he has also continued to have lots of connections in China. And so we knew relatively early on about the problem in Wuhan. And in fact, we were writing our first paper about SARS-CoV-2 and COVID-19 in the middle of January of this year. We had it published towards the end of January. And in that paper, the Chinese government had already instituted a lot of the standard policies now of social distancing, quarantining, masks, and so forth. And there were less than 100 cases in the United States at that time. Our particular interest actually wasn't COVID-19 per se, it was the impact it would have on our particular area of interest, which is health-related quality of life in older adults. We know that sedentary lifestyles increased the risk of having an underlying medical condition, which then increased the risk that if somebody did get COVID, that they would have a poorer outcome. So our interest was in recognizing that the quarantining and social distancing would interfere with people's ability to engage in physical activity, and that then could have a knock-on effect and be very problematic. So we're writing a paper basically looking at ways that people could try and maintain an active lifestyle under quarantine circumstances in order to minimize the potential consequences of the efforts to try and contain the disease in China. And obviously that would apply anywhere. The last thing I wanted to bring up, sort of the framework for tonight's lecture, is the thing I have there. It's called, I'm going to be looking this at as a multi-system question. In all of my classes, I talk about a 3-system questioning protocol that was developed by Paul and Elder, some people who were write extensively about critical thinking. So I think about a no system question. This is one where there's no right or wrong answer. It's purely subjective. What's the best flavor of ice cream? There isn't any way to resolve that particular question. A one system question is exactly that. There is a right answer and a wrong answer. If I say, what's the atomic weight of lead? There is a mechanism for saying this is the right answer. But a multi-system question, these are the ones that present us with the most difficulties in our lives. These are ones for which there are no right or wrong answers. What you have are better or worse answers based upon the evidence that's available, based upon the criteria that you're going to be used to evaluate that evidence, based upon the competing credibility of the sources of information that you bring in. And it can be really hard because you might be trying to resolve a philosophical question, a philosophical argument against an economic argument. So these are ones in which I try to give my students lots of practice. And this is the approach that I'm going to try to utilize in covering this question tonight. So that brings us to the question of why people are not listening to the science. Well, here it is, one slide, and then I'll go home, because life is complicated, which means science is hard. And I like this particular cartoon, not just because it encapsulates some of the problems that we have right now, but because the path that you can see here for the science is what it is. Science is a long and winding road with lots of false trails. And knowing this, scientists are generally conservative in their pronouncements, especially related to new investigations, which then often puts science in sort of a no-win situation regarding the public, such as we're seeing with COVID-19. If definitive assertions are made and then later found to be incorrect, which often happens, science loses credibility, kind of like the boy who cried wolf. But if scientists attempt to be realistic and couch their announcements with limitations going out to the general public, noting, for example, that current knowledge is conditional, then it's seen as lacking authority. In essence, it's no better than guessing someone's personal experience. In uncertain times, people want certitude and reassurance, and they're looking to science to provide it. If it doesn't, they get scared and frustrated and angry and disillusioned and depressed and just contrary. But why science? Well, because in general, its goals align with our overall well-being. Ultimately, this is a little model that's sort of a steal from Loon's taxonomy and a couple of other sources that I also present in class. That any sort of scientific inquiry, questions about the way the world works, has to start with the concept. Somebody has to have some idea to even sort of think, recognize clouds as being something that could be investigated. And it runs through sort of theoretically these steps. Fundamental science is about observation and description. You try to sort of explain phenomena, observation and description, explain phenomena. Ultimately, it would be good to be able to predict it. This is what weather forecasting is all about. But the best thing then is to be able to control it. So these ultimate goals of predicting and controlling the functioning of the natural world, in essence, to stop the bad things, diseases and natural disasters, things that cut our lives short or make our lives miserable, or to increase the good things, science to improve food availability or improve physical functioning, those things that improve our quality of life or extend it. That's why we look to science, because it can do these things. It's not magic. It's hard to get there, but we've seen, particularly over the last 100 years, significant advances in quality of life. I'm not denying that there are unfortunate negative consequences as well, but overall, we're moving in the direction of science is really a way for us to try and find a better life. So we talk then about epidemiology, and it's a science. What is it? Epidemiologists are at the forefront of this research in COVID-19, and they've been pushed into the public eye as experts producing the science that should be listened to, and most people don't really understand what the field entails. The common definition of epidemiology is the study of the distribution and determinants of health-related events. It focuses on what happens in groups and populations rather than what happens in individuals or at the individual level. This is a pretty famous little cartoon about it. So I also have this in my epidemiology class. Something that you do is going to cause some bad thing in your body to some group of people. So this is fundamentally what epidemiology is about. But it's interesting because it's often described as a low-tech science. You don't need a lot of complicated equipment to do it. In its basic conceptual form, it's not complicated. When you start dealing with some specific stuff, it can get really, really complicated. But basically, when we think about how does it work, in my MPH program up at OHSU, this is a big reveal. What do epidemiologists do? They count stuff. That's it. That's what if you're an epidemiologist, you just count stuff. And if that's all there is, why is it so hard? Well, there are a couple of things. The counting the stuff is important because we need that data to identify patterns that might be occurring in the natural world. And those patterns are important because the basic premise of epidemiology, we're looking at health-related events, is that health-related events don't occur randomly. Right? And so if we have the appropriate data, we can start to uncover the patterns which would identify some underlying relationship between different variables of interest, risk factors, and health-related outcomes. The problem is getting the data. This is where epidemiology is really hard. It's really hard because you have to have an appropriate data capture system. You have to have some mechanism for identifying and recording the events of interest that you're going to use in your analysis. You have to be able to identify primarily, divide the world into two halves, cases and not cases. People who have the health-related condition we're interested in and those who do not. And sometimes identifying the case is very difficult. We think about somebody who, if I'm investigating upper respiratory tract infections of some kind, for example, I have, let's say, some particular, like COVID, new kind of respiratory illness. It may be presenting with the same signs and symptoms as 6 other upper respiratory tract conditions. And if I miscount, if I count somebody who has one of these other conditions as a case, somebody who has the condition I'm interested in, then the data are not going to clearly show the pattern that I'm looking for. In essence, it's going to mess up, it's going to muddy the waters. So being able to characterize a case clearly, being able to measure cases accurately, that's tough. And then having an appropriate data collection system to make sure you capture all of those data, all of those cases, and be able to collect the other samples that you want, that's hard. And part of what makes it hard is good data. Generally, we're looking at large sample sizes, long periods of time. Now, that's not always the case, but that helps us to get past perhaps temporal anomalies. Sometimes there are spikes that occur in a short period of time. And if we just take data from that period of time, again, we get a very different impression about the pattern of this health-related event and its antecedents and consequences than we would if we had looked at over a long period of time. So, and that's where some of the confusion at the source comes with people taking note of recommendations from the health authorities about COVID-19. This was a line that came out of an article that was in the New Yorker a couple of weeks ago. The epidemiology behind the disease is in flux. Well, yeah, absolutely, because there is still so much that we don't know about it. Even the natural history of the disease is still trying to be uncovered. But what we do know and things we can measure, even those things are not standardized, and they're not standardized for a bunch of different reasons. So, for example, this is an assignment that I gave to my epidemiology class earlier this semester. These are two data sets that came out of the New York Times and Times Magazine that was looking at the same information on the same day, September the 5th. And what we can see here is we're looking at new cases and percent change over 14 days. Here we're looking at, this is the New York Times one, 42,000 with a 7% decrease trend over the last 14 days. But Time Magazine, we're seeing they had 50,000 and a 1.3% decrease trend over days. So given that these are two reputable news sources, the impression is that no one knows what the real story is because, and so the impression is that nobody knows what the real story is because too few people really understand the difficulties of collecting the epidemiological information or appreciating that though the numbers may be different, strangely enough, it doesn't necessarily mean that they're wrong. Right? You would have to say, is the data collection system that they're using, is it a credible system? If you have two different systems and they're both constructed appropriately, you can be getting different numbers. Those numbers are both going to be accurate. And when you have comparisons of systems like that, what would be important to do is to be saying, okay, how are they converging? And in both of these, we can see, even though the numbers, okay, so they're 8,000, but in the greater scheme of things, that's not a huge difference. But what's interesting is the trend is downward. And that would be the thing to take away from it. Even though the magnitude of the trend is different, they're both at least agreeing that the trend is decreasing and that people should be trying to understand that perhaps more information from different sources that is all indicating the same thing, even though the magnitude might be different, is something that you can take comfort in, not something that should be distressing, because they're not exactly the same. This is a similar thing. It's a slightly different look at looking at the data slightly differently. This is from New York Times. Again, they do daily updates. So it's a great resource. Looking at the total cases and cases per 100,000 in different counties in Oregon. So what's interesting here is that they're presenting the same data in different ways, and that can be really confusing to people. So on the one hand, you can say, people look at this and go, well, wait a minute. So which is the more, where should I not live? Should I not live in Multnomah County? Because look, they're the highest rated. This is where most people have become sick with COVID. Or should I not live in Malheur County because they have the highest rate of cases per 100,000, in essence, a standard metric? Why are there these different numbers? People don't understand that each of these has a different purpose. So, for example, the total number of cases is important for us, perhaps for resource allocation. If you have many more people who are coming down with the disease, let's say seriously, then you might want to be shifting ventilators or other kinds of therapeutic interventions up into Multnomah County because you've simply got a greater number of people that are going to need them, much more down in Malheur County where there's only 1,000 people. Whereas if you're trying to figure out how to perhaps best identify where prevention efforts would be most beneficial, then you'd be looking at something like this, where we're looking at the rate per 100,000, saying, boy, the risk here is really high. We want to try and figure out how to intervene here to try and stop this from progressing. So if people can't understand that these different data representations have different purposes, that can undermine people's confidence in the data and then, again, lessen its impact on prevention behavior. The last example of problems with data source interpretation, these were actually pretty interesting the way these showed up. So this was an article that was online about the suspension of widespread testing in nursing homes in Nevada because there had been some anomalies, and it's a longer story than I'm showing here, but basically it said what they were finding were that they were having some, as it says here, a spate. And as it turned out, it wasn't very many, but a number of false positive results. And then they decided to discontinue it until the quote-unquote accuracy of the test could be evaluated. Okay, so a false positive, as many of you probably know, is that the test is indicating that somebody has a particular condition, has COVID, when they don't. Almost at the same time, I think it was like 2 days later, this came out after what happened at the White House, and this person was saying they all were tested and they tested negative. But here, the response was people know that test that is used at the White House has a high rate of false negatives. So in here, the test is basically telling a certain percentage of the tests are saying people don't have the condition, and in fact they do. And so you've got a situation where perhaps people are saying, well, wait a minute, a false positive test, a false negative test, why don't they just make good tests? And because testing has been touted as a really important mechanism for trying to control the spread of the disease, we don't have widespread testing in the United States the same way as they've been using it in other countries. And so people are confused, the tests don't work, and they don't understand, for example, that there really is no perfect test. They all have some magnitude of misclassification characteristics, these false positives, false negatives. A perfect test would be one that identifies everybody who has a condition absolutely accurately and also identifies everybody who doesn't have the condition absolutely accurately. So those things don't occur. So you're left with then some misclassification, false positives and false negatives, but they're not equally, they're both good and bad. And there are circumstances in which having one is preferable to having the other. So, for example, in the current situation, I think you would find people who work in the field saying, if I'm going to make a mistake, I want to make a mistake with false positive. I want to be capturing people. I want to make sure I capture everybody who has it. And if I am capturing a few people who don't have it, that's good, right? Because you don't want to miss anybody that has it. The false negative would not be a good test to use here. You wouldn't want a test that is letting people who have the condition not be identified, and so they would be out in the community and continuing to spread it around. So even though these are inaccurate, they're inaccurate in different ways, and those inaccuracies can be beneficial or detrimental, but beneficial if they're utilized appropriately in a particular situation, as I just explained here. But again, trying to get the general public to understand some of the nuances that are involved in these things is very tough. And so that leads us to the place of public health in this whole process. So public health, which has multiple components. I mean, public health as a profession is extraordinarily complicated, and it involves, as they say, policy development. It involves utilizing research. It involves trying to build infrastructure and so forth. But simply put, the most simply put is public health is a mechanism for translating epidemiological information into action. Okay. So epidemiology is the foundation of public health related information. But strangely enough, the ineffectiveness of just presenting information, health-related information to the public and expecting change, it's really well known. I mean, in fact, the entire profession of health psychology, not to mention consumer product advertising, owes its existence to this problem. You can't just tell people things and expect that they're going to change their behavior. It's also why what I've got here said here is more effective approaches to public health have evolved. So the first step, educate, right? We've got the information, we're going to put it out to the public and then, let them know that they're at risk because they don't know they're at risk. So we're going to tell them they're at risk, and of course, then they'll change their behavior and that'll be fine. Well, that doesn't work very well. And that's demonstrated over and over again. Just providing health information is of limited utility for a variety of reasons, some of which I'll talk about in a little bit. So the next step up is to try and say, okay, we will legislate it. We're going to require people to change their behavior based upon the information we have that is designed to identify things that are good or bad for them. And then if that doesn't work, we're going to take it out of their hands altogether and automate, right? We're just simply going to take that decision away from them. And we might think about this in terms of controlling goiter, goiter is a kind of a benign tumor that occurs in the thyroid gland because of lack of iodine in the diet, and it's endemic in many countries. It's even in the United States and Australia in the early part of the 20th century. When I was younger and working in a department store, I worked with a lady who had a goiter. She was probably in her 60s or 70s at that time, so she was young in the early part of the 20th century. So iodine deficiency was pretty common. All right, so iodine is added to table salt, and goiter is no longer a public health problem. We see the same thing with niacin added to bread, so that pellagra is no longer a public health problem. It's not left to say to people, eat this kind of food, or you can't force them to do it. You simply build it into their daily lives, and that's an effective way of having public health interventions effective. Unfortunately, it also produces a certain amount of, let's say, pushback. So, with all of the available data about the genuinely catastrophic impact of COVID-19 on global health, why isn't telling people about the hundreds of thousands who have died enough to have complete buy-in? So there are multiple explanations for why the educate doesn't do it. And here are two, I think, that are pretty prevalent. The first one is, I think, a conflict between intellect and emotion. So although most people understand that can understand the risk on an intellectual level, it just doesn't resonate on an emotional level. And emotion is generally a much more powerful driver of behavior than intellect. For most people, death is usually an abstraction, especially in large numbers. Although we will all suffer directly when we lose a loved one, the intensity of the emotion fades with time, and that's actually a good thing. The dampening of the sense of loss and grief is a survival characteristic. Without that, we would be rendered incapable of functioning in the world. And can you imagine if that sense of grief was magnified tenfold or 100-fold? People would be catatonic, would not simply be able to survive. So emotional distance, whether it's deliberate or innate, protects us in the long run, but then it also separates us from strongly connecting to motivations such as protecting people we don't know from illness or death. The second sort of psychological phenomenon I think is at play here is cognitive dissonance, that the information that's presented conflicts with a person's established worldview. So they're driven to try and resolve that conflict. In the case of COVID-19, maybe by denying the information that's presented to them. So, for example, if people really believe that the United States has the world's best medical system, but are then told that the US has the world's worst outcomes for COVID, the easiest resolution for that conflict is to ignore or deny the COVID data and then consequently ignore the attendant recommendations for controlling the spread of the disease. I found that the argument that COVID is no worse than the flu to be a particularly interesting strategy to resolve cognitive dissonance in this case, because at its core, that approach involves normalizing the 30 to 50,000 excessive deaths due to the flu that occur each year. In other words, even if COVID was no worse than the flu, people with this view are stating that it's reasonable to have an additional 30 to 50,000 people die annually, and I shouldn't really be asked to do anything to rectify that. The next sort of category beyond the not connecting with the information, not sort of connecting, is actively opposing the information. And we live in a pluralistic society, and that can be both a blessing and a curse, as you can see here. Poor Bob stuck in the middle between women's march to end male-dominated society and the ladies' march to stay in society's traditional roles. And so what's interesting about looking at competing values as an explanation for people not listening to the science is that there's an underlying assumption for those who are pressing for everybody to follow the COVID-19 safety recommendations is that life is the ultimate good or the singular value. However, there's abundant examples in history and currently where that's clearly not a universal belief. That being the case, you have people working at cross purposes, and the challenge is finding a point of commonality where a compromise can be reached. Unfortunately, that's easier said than done. So we have people who say, if you don't have your health, you don't have anything. Give me liberty or give me death. There's a gap right there in attitudes that would come to play in terms of recognizing the recommendations that come from COVID-19 public health authorities. So here are just three that right off the bat. So in the current situation, the economic considerations have probably been the most obvious source of resistance to listening to science. Despite the scope of the pandemic in the USA, for the vast majority of people, unless they have personally known someone who has been seriously ill or died, COVID-19 is really just a news headline. However, the impact of employment furloughs and terminations because of the pandemic, they're immediate and they're real. So it's not unreasonable under this situation for people to push back against what they perceive as overkill in the efforts to contain the spread. Similarly, we've got significant opposition to the mandates limiting social gatherings from religious groups. So, and it should be no surprise that people are willing to sacrifice their lives in response to what they perceive to be attacks on their faith. The protests in New York last week, some with violence following Governor Cuomo's new restrictions on schools, businesses, and houses of worship by both Jews, commentary from several Jewish state lawmakers. He has chosen to pursue a scientifically and constitutionally questionable shutdown of our communities. And from Catholics, so the Archbishop of New York saying the religious freedom of our parishioners is being unjustly attacked, highlight that problem, this diversion of values that then presents a place of disconnect where people are simply not willing to do what might protect their life because their life is not as of greater value as one of these other values. And of course, there are a multitude of personal philosophies that exist that run counter to aspects of public health, these public health directives. And people have been clearly willing to die for what they believe in, even if their death could be avoided by adhering to some simple behavioral adjustments. Risk tolerance. And so this is something that's problematic, even if you decide you're going to follow the recommendations, you believe the science that this is a problem and you need to be able to do something about it. We don't all have the same level of risk tolerance, and that's an issue because that means the degree to which we're willing to follow these recommendations could fluctuate. Right? I use an article in the start of the epidemiology class from a number of years ago called The Myth of a Risk-Free Life. And so this idea of a risk-free life is somewhat prominent in our society, and science is to some degree to blame for it, that we've shown that we can overcome a lot of things which would have resulted in our deaths much earlier. I mean, expected life expectancy in, for example, the United States now is significant. It's decades longer than it was even a century ago. And a lot of that has come from science. And people have then come to the idea that you can have a risk-free life. And of course, you can't. There isn't any way to reduce risk completely from our existence. I'll learn how to spell. Apologize for the editing error on tolerance. And so one of the things that crops up here is this problem of possibility versus probability. And how much should I be adjusting my behavior based on something that's possible as opposed to something that's probable? So just last week, the CSIRO, which is the Australian government scientific research organisation, published some findings that said that SARS-CoV-2 can exist for up to 28 days. That was what was put in the press. Of course, when you read the report, it says only under certain conditions, and those conditions are fairly stringent. But it's possible. How probable is it? And that hasn't been established. It's the same thing with the aerosolization from toilets flushing. There's a lot of talk now about it's not vapor, it's aerosolization of the particles, and that's a great risk. And it's a controversy even in the scientific community as to how significant that is as a mechanism for transmitting the disease. So it's a tough thing to say, just because we're inundated with information that says this is possible, it doesn't mean it's probable. And that's a sort of a difficult analysis to make. How much risk are you willing to take? And we all have different risk tolerances. And so you might be willing to say, you know what, I'm willing to wear a mask and I'll social distance, but I'm not willing to, not meet with my friends if they're similarly distanced, for example. Other people will say, you know what, I'm just not going out of my house. If people deliver groceries, I'm going to wipe them down, and so forth. So that level of uncertainty is also kind of problematic. And then finally, we get to sort of pandemic fatigue. This is being talked about more and more in the literature and in the newspaper. So we know that sort of unremitting stress can result in self-preservation measures that may be counterproductive. People need reassurance in these stressful and uncertain times, and they're looking to science to get it. But science is, well, here's what we know, but. So they're going to turn to sources that provide certainty, and that's where that's the field in which conspiracy theories flourish. Here's what we know for sure. And that's a major problem right now. A study by the University of Pennsylvania Annenberg Public Policy Center published last month found that conspiracy theories about COVID-19 are gaining traction across the country. One of the authors noted, conspiracy theories are difficult to displace because they provide explanations for events that are not fully understood, such as the current pandemic, play on people's distrust of government and other powerful actors, and involve accusations that cannot easily be fact-checked. And so that's a major problem because they provide people with a rationale and incentive to ignore public health recommendations. So we need a solution. And this is a pretty famous cartoon here. This is what we're looking for. Unfortunately, it says we need to be more explicit in step 2 here. So what is the solution? We go full circle. Life's complicated, and there is no silver bullet. Given the complexity of the situation, solutions are obviously not as easy to identify as problems. However, knowing the problems is the starting point for finding the solutions. In general terms, there needs to be a broader understanding of the nature, strengths, and limits of science in the population at large. That's a long-term project. Concomitantly, researchers and policymakers have to have a greater appreciation of the validity of the worldview of those who are not listening to the science. Until these things happen, the likelihood of finding common ground on which to develop compromise is low, but the likelihood of the rift becoming greater is immense. Right. Thank you very much. Everybody stay well.
For the audience, a few questions have come in, but if you do have some questions, please again use the Q&A feature below. Before continuing some of the COVID information, Peter, just before we started broadcasting, you mentioned I missed a degree in the introduction, one that you had obtained from a college in Australia. I was just curious, how did you end up moving from Australia and ending up at Willamette?
Well, actually, that was via Japan. So I was originally qualified as an elementary school teacher in Australia, and I taught there for several years. But I was a competitive judo athlete, a judoka, and the short version of a longer story was I had a pretty serious injury. I stopped competing. A friend of mine that I had always beaten had gone on to win the national championship. When I recovered, I thought, well, let's see what I can do. The only way I could catch up was to go and train full time. So I took a leave from my job in Australia, went to live in Japan. And I was only going to do that for a year, and that ended up being 4 years. I quit my job, I stayed there, and I just did that, trained 3 times a day, 6 days a week for 4 years. In the meantime, a number of my friends who were undergraduates with me in Australia had decided to come to Oregon to go to graduate school. Oregon has had since the 50s a very good reputation in exercise science, physical education in Australia, and so they had come over to do that. And I thought, well, I'll come over and I'll do that too for a year. And that was 40 years ago, so it didn't work.
Well, we're certainly glad that you've been here for 40 years.
Thank you.
All right. So moving into some of the questions from Mary Stewart, I think this is in reference to the numbers that you had shown. How does a resource for testing or the frequency of testing affect the numbers that you had shown?
Well, again, I can't actually speak directly to it because I'm not sure of the kind of testing that's being done. But obviously, the more testing you do, the more cases you're likely to catch. And so the more cases you're going to see, the less testing that you do, the lower the numbers are going to be. And that's that's been one of the criticisms about the way that the White House has been demonstrating, hey, look, we've got this under control. See, there aren't very many cases. Well, there aren't very many cases because they're not doing as much testing as they were doing in Europe, for example. Hey, we're doing better than Europe because we don't have as many cases. Well, if you don't test, you're not going to find them. And so I think it's pretty straightforward that way. People are arguing for more testing so we get a more accurate picture of how extensive it is. But the more you test, the more likely you're able to find the cases that you need to find to be able to track contacts, to do the contact tracing and isolate. So this is the primary way of trying to restrict the spread of this.
Has there been significant research to support the probabilities of picking it up from the grocery store? So again, that possibility versus probability.
No, there really isn't anything that says that can definitively say here is the probability that you're going to be able to contract it this way. And that's because there are just too many variables, right? What grocery store, what time of day, in what part of the city, what kind of groceries are you picking up? There are these generalities. And again, it's not unusual. People want to know, tell me specifically, and we can't, right? Because there are just too many variables. It's one of those things where, people are saying, well, if I can go to the grocery store, why can't my kids go to school? Well, what is the difference between the grocery store has lots of people in it, and the school has lots of kids in it. But the grocery store, the actual cubic footage in the grocery store is going to be significantly bigger than for the school. You've got ceilings that are, 30 feet high. And so you've got, even if there was a case there, potentially the diffusion of the virus in that space would decrease, theoretically, the probability of a transmission. Whereas, and this is a big one now about ventilation, being in poorly ventilated spaces with somebody who might be contagious is likely to increase the probability that somebody would get sick. But it's not, and that's the other part, of course, it's not guaranteed. We have people who are resistant to it for all kinds of reasons, just the same way as we have people who show much more significant signs and symptoms than other things. Lots of individual differences that can occur there.
Next question from Brian Cloxon. I hope I'm getting that right.
Hey,
class of 94.
Yes, Dr. Cloxon, thank you very much.
What do you see the role of IHEs, and if you could elaborate on that acronym, like Willamette, in preparing students to address pandemic-like problems?
Well, I'm assuming an IHE is independent higher education, but Brian clarified. There you go, Institute of Higher Education. Well, I think the role is the contribution it can make is the fact that you are exposing students to the intersection of knowledge across different fields, and that's the key to what's going on here. I'll give you an example. Actually, a solution. This was I just read this in the New York Times today about a woman named Heidi Larson, who is the founder of the Vaccine Confidence Project. And basically, what the project is designed to do is to try and track down rumors about the dangers of vaccine and try and get those dispelled and get people to buy into the validity of vaccines. And and what I found interesting is that in order to do that, it's not about the science. She says the Vaccine Confidence Project, which began in 2010, comprises more than a dozen staff with backgrounds in political science, psychology, mathematical modeling, epidemiology. So these are complicated issues. And science, as I just talked about, science by itself isn't going to do it. You've got to figure out, how do you effectively communicate that information? How do you connect with people emotionally in a way that the information is going to work? And that's where institutes of higher learning like Willamette, the traditional liberal arts colleges where students get to see the intersection of different disciplines, can lead to new approaches to dealing with these complex issues. As I said, it's a multi-system question. There are not better or worse answers. Sorry, there are not right or wrong answers. There are better or worse answers. And those better or worse answers depend a lot on what do you bring to the table. The more information that you can bring in, the more fully you can try and identify where the problems are and look for unique solutions.
We have quite a few more questions, actually. I hope that we were able to get through all of them.
Okay.
From Catherine Hammond, what were some of the best ways you found for older individuals to remain physically active under these circumstances? Did you also research medically fragile individuals?
Okay. Well, actually, it was a little bit self-serving, the recommendations we made. Some of you might know that the primary research work I do is in fall prevention in older adults through exercise. And the exercise intervention we use is a modified Tai Chi program that my co-investigator, Dr. Fuzhong Li, developed. And so we were making recommendations for exercises like that. So we have demonstrated its value even with frail older adults. We've had people start our program who are chair-bound, can't walk without a walker, and have improved their physical function over the course of our project. It's not the only one, but basically you could be looking at anything which is requiring the individual simply to be moving around. So, I saw a really interesting video, I think, that came out of Spain or Italy of older couples who were quarantined, and they're continuing to dance. They spend their evenings dancing in their apartment. As people who have come through our program know, your body can't tell whether you're carrying a 10-pound weight in the gym or you're carrying your laundry up the stairs to your house, right? It's a demand that's being placed on your body, and if you place those demands on your body appropriately, it's going to adapt and your physical function is going to go up. So in circumstances in which individuals are housebound, you're looking for things which are going to be sort of the ideal things are ones which are going to require little or no equipment, ones which are able to be paced by the individual themselves, self-paced by the individuals. And one of the classic one is, and the activity that the person's interested in, because it's tough to keep people active if they don't like what they're doing.
What's the most surprising thing you've found in your evaluation of COVID-19 data?
I think the most surprising thing, and it may not be surprising because we know it's mutating and because we don't have a good understanding of its natural history. But the most surprising thing is how we're seeing different profiles in terms of who's most at risk or how it's transmitted across different countries. That's so it's like, well, we're looking for certainty. People in the United States say, for example, well, I'm in the high risk category because I'm old, right? So I'm an older guy. So in the United States, we're told, well, if you're old, above the age of 65, you're a high risk individual. And I just read a couple of weeks ago, an article from a huge study that was done in India. And what they were finding is, in fact, that the fatality rate in people over 65 in India is lower than the fatality rate in younger people. And again, there are ways we can explain that when you investigate it. So, for example, in India, generally, if you live to the age of 65, it's because you're fairly well off. And so you're likely to have, good food, good housing, good sanitation, good medical care. Where the vast majority of the population are likely to die off earlier, just the same way as it was here in the United States in the early part of the 1900s because of poor sanitation, poor nutrition, and so forth. So when you look at the data, it says, boy, if you're old in the United States, you're more likely to die. Well, that's because old in the United States usually is unhealthy. And we have a lot of people who, over the age of 65, have significant underlying comorbidities. And so are more at risk. Whereas in India, those people have probably died off. And so if you can make it to 65, you're looking at a smaller segment of the population, but that is more robust.
Great, thank you. And I forgot to say who asked that question. Connor Ebbinghaus.
Okay.
All right, next one from Amy Josephson, class of 93-94.
Yes.
In your current research, do you see it relevant to retest positive patients until negative?
Yeah, Amy, you're asking questions way above my pay grade, as she was wanted to do. She really liked to put me on the spot. It's very, very rude of you, Amy. No, I don't know where that stands. Truthfully, I don't know where that stands at the moment. Retesting after positive, obviously it's happening because that's a big question right now. Can you be reinfected? And that's a controversial. There seem to be cases in which people have been reinfected even within a couple of months. So from a research perspective, certainly we should be trying to continue to do extensive testing with people who have been infected to sort of fill in some of those knowledge gaps. But in terms of public health policy, that's one of those ones that I'm not in a position to figure out what the cost-benefits ratio would be.
And another follow-up question from Amy. What are your thoughts of the couple of cases of different strains of SARS-CoV-2 in two different European countries?
Yeah, and I don't know what to say except, we know that it's mutating. There was a really good segment on 60 Minutes on Sunday night with Dr. David Ho, who talked a lot about this. And so it's not a surprise. And again, it's interesting. People tend to think about this as though it has intent. Right? It doesn't have intent. It's just it's a bunch of chemicals wandering around, sort of following the path of least resistance in order to have it self-propagated. And so mutations that are going to continue to keep it propagating are going to show up because you're going to have people who have different resistances and so forth. So, I don't see that as being a big surprise. And in fact, the fact that there are only two, I think is not correct. I think there have been more than that have been identified at this stage, and more to come. What was interesting to me early on was the research in coronaviruses that's being done at the Institute in Wuhan, and there are millions of coronaviruses that they've identified. So we think about, it's this one, there's SARS and there's SARS-CoV-2 and there's ones associated with the cold, but there's a lot. And so that's a major worry as to how many of those might mutate across and end up in the human population like this one did.
All right. From Colby Takeda.
Yes, hey, Colby.
Given the current public health crisis, are we seeing a greater interest in WU's exercise and health sciences and public health programs?
That's a tough question. Not yet. I think it's been far enough. I will use that as a jumping off point, Colby, that, the exercise and health science program has been the most successful program on the Willamette campus over the last 10 years in terms of growth. So it's clear that students are coming in and are interested. And what is interesting about that is that of our graduates over the last 25 years, of many of whom have called in, about 40% have gone on to careers in healthcare across 17 different healthcare professions. So absolutely, as more students are finding out about exercise and health science as a route to a career in clinical healthcare, more of them are coming on this way rather than the traditional chemistry or biology, which doesn't really deal with anything human along the way. And our whole thing is understanding human function. The field program is just getting off the ground. It will be interesting to see how it goes. It's received a very generous endowment to help it get going. So I'm sure that will draw some students in. What we're hoping for, we already know that unfortunately it's a little bit in conflict with us in terms of majors, but what we're seeing, which I think is a good thing, is a number of students double majoring, which makes sense that you would double major in exercise and health science and the public health ethics advocacy leadership program.
Great. A question from Kelly Van Hook. How do you think the pandemic will change the administration of healthcare services long term?
I don't think it will. I would be surprised. It's not a surprise. I would be surprised if it does, because this is not a surprise. We knew this was coming. In fact, many people know that the George W. Bush White House, he was the one that he saw this, and he was the one that started the national pandemic plan that was finished up under Obama, that was unfortunately dismantled under the current administration. So we understand what's involved. Maybe if anything is going, until there is a change in political will, you're not going to see significant changes that will allow us to deal with these things in the future. I mean that's the bottom line. It doesn't matter how much healthcare providers are saying, look, we know this is coming and here's what we need. Unless you can have that kind of support, we're not going to go anywhere, because, again, there was a plan in place to deal specifically with this scenario. And it was taken apart. We should never have been in the situation that we're in at the moment, given what was started, several administrations ago, recognizing that this moment could occur.
All right. Next question from Katie Vinson. Hello, Professor Peter.
Yes,
Professor Harmon.
Yes, and another clinical healthcare specialist from our program.
She knows that your research revolved around how to keep older adults active. But what is your view on the mental health effects of the isolation and quarantine in older adults? And how do you think this affects how active they are?
Yeah, that absolutely is a huge issue. I don't think there's any question that it's having significant negative effects, particularly those individuals who in isolation have no ability to communicate with others. We knew this even before COVID came around. We knew this with, what used to be called shut-ins, those people who are isolated. This is one of the great things, for example, about Meals on Wheels. Many of the people who work with that say it's not about the food, it's about the company, it's about the able to have some social interaction. So I think that there is no doubt that individuals who are shut off from social interaction older individuals are going to have very poor mental health consequences. And that's something, again, that needs to be looked at, and interventions to try and alleviate that developed. And that may be something like, can you build a program where those people who don't have technical access, that you can get them a little cheap computer with internet access, so they can do some, FaceTiming with their family if they have them, or with their friends, or with random strangers, left like Meals on Wheels. There's got to be something. What the magnitude of that problem is at the moment, I don't know, but I dare say those people who work in elder health, particularly with individuals who are typically homebound, are going to understand the extent of that problem. And it is one of those additional, initially unforeseen consequences that are going to have long-term impact that needs to be addressed.
Question from Josh Rice.
Mm-hmm.
Reviewing past viral history and the potential mutation cycle of the virus, how long do you see it taking before international travel or travel in general is encouraged and resumes?
No clue. Yeah, it's a good question. People are saying, well, it'll happen after we get a vaccine, and the vaccine is widely distributed. If you talk about the people who are doing vaccine research, even if they developed a vaccine tomorrow, being able to manufacture, distribute, and apply, 300 million doses, that's just a huge logistical problem. It's not going to happen overnight. And we don't know when the vaccine's going to come. And even if the vaccine, how effective it's going to be. But what I did find interesting, again, in the same, I think it was in the same 60 Minutes interview, they were looking at vaccine. 60 Minutes. They were talking to a whole variety of people involved in some of the advanced clinical trials for the vaccines that are going on now, and the interviewer asked them all, asked these people who are actively engaged in this research, vaccine or a mask, which is better? And they all said a mask, because it's cheap, it's implementable, it works. Right now, a vaccine is at best a hope and a guess. So I found that to be particularly interesting. So how quickly we will get back to international travel, I don't know. There are a lot of variables at play there. So, and again, that's partly risk tolerance. We know international travel is still occurring. So, okay, how much are you going to open it up? That's going to depend on whether people want to take the chance, not whether the opportunity is there. That's another part of that problem.
Question from Mary Stewart. It seems there are a lot of sources, in quotations, of information out there. Are there some resources you would recommend to check for current data and accurate data, and potentially how you would best educate yourself and advise behavior for family members?
Yeah. I think three that crop up in my mind. Johns Hopkins School of Public Health, that's been a mainstay of information. That's a really good one, obviously. I really think the New York Times daily updates and the way they've been covering it is very good. And again, I'm going on their credibility as an independent news source. Obviously, if you can get information from NIH, we all understand Dr. Fauci has been a beacon of good information, albeit, he's been honest. He's done what I talked about in the beginning, which is hamstringing the science to a bit. He's saying this is the best information we know at the moment, and it might change. So I think those off the bat would be the three places. The CDC should be, unfortunately, given some of the recent stories about the political pressure on what's happening at the CDC, I still think it's obviously a good place to go, but it's starting to get a question mark put over it, which I think is extraordinarily shameful.
And last question, for those who have submitted other questions as well, or think of questions after the presentation is concluded, feel free to send an email to alumni@willamette.edu, and I'll compile the questions. I'll send it over to Professor Harmer, And I hope he's up for responding to each question.
Well, and for those, I'm assuming most of the people who are still hanging around know me. You know how to get a hold of me. That hasn't changed. So feel free to drop me a line. It's always wonderful to hear from you guys.
All right. And last question from Beth Cole Leons. I hope I'm pronouncing that right. Class of 2002. What words of hope can you leave us with?
I think the words of hope are that, as frustrating as it is to see the people who aren't taking notice of the recommendations, that the majority of people are. I mean, I think most people are willing to make some sacrifices, and the sacrifices, the vast majority of the sacrifices are not difficult. Wear a mask, maintain some distance, be circumspect in the way that you interact with other people. Those are not huge asks. For some people, there are bigger demands. Parents who have children that have to stay at home because their school has gone completely remote. How do you balance that against trying to do your job? Those things are tough. But hopefully, if the thing that people would say, what makes the United States, what made the United States a world leader in healthcare, in democracy, and so forth, it was fundamentally there can be differences in the community, but people all pull together. And I think that's ultimately it. That's the hope we have, that we have people that will all pull together.
With that, Peter, thank you so much for your wonderful presentation and for answering all of those questions.
No, it's my pleasure.
Hopefully our audience comes away with a better understanding of epidemiology and also the driving factors behind the prevalent resistance to some of the public health recommendations that are out there. Before letting our audience go for the evening, I'd like to give you a quick moment to share what's going on with you and the department. Anything cool, exciting coming up?
Nothing. This is it. No, the program is continuing to do well. It's always exciting to have new majors come through, leaders on new paths, and people going out. When the majors graduate, love hearing back, seeing the paths they follow. They're showing us new opportunities, things that we've never thought about before. When I talked about clinical healthcare careers, this, I think, 17th different one, just maybe within the last couple of months, a former student wrote back and said she's now a pediatric echocardiographer. And I thought, okay, I can add that to the list because we've never had one of those before. So for all of you who are listening, please keep us updated on what you're doing. That's important for us because we're interested and we'd love to keep track of what's going on. But it's also important so that I can continue to tell incoming students, here's what you can do with this degree. And whether it's healthcare, whether it's business, whether it's education, whether it's public service, which all of our majors have gone on to do, all of those things are wonderful opportunities that grow out of understanding human function. Thank you all for taking that message far and wide.
All right. Thank you, Peter. And thank you, our audience, for joining us today. If you enjoyed this presentation, make sure to check your emails, check out Willamette's alumni social media pages, subscribe to Willamette's YouTube channel. Yes, we do have one, to hear from alumni, staff, and other faculty. Also, please send your suggestions for future guests, future programs, future topics, and your feedback to alumni@willamette.edu. With that, thank you, everyone, and take care.
All right. Thank you. Good night, all.